The first session on this side for actually this is the session for the afternoon will be led by Patty Cason, who is assistant professor of nursing at the College of Nursing at UCLA. But Patty's real role in the national family planning scene, there are many, but the one I know her best at is trainer extraordinaire, and she has spent, I think, more time thinking about and definitely doing training and helping people inform their patients about better ways to deliver contraception and counsel them, and tips and tricks on providing that kind of care than I think anybody else. And I have worked with Patty in a variety of settings where we've trained people, where we trained the trainers to train people to train other people, and every single time I walk away with a few nuggets when I feel like, I've heard her spiel enough times now, or some new angle, this time probably not going to get anything new, but nope, every time there's more. So if you're hearing her speak for the first time, get out your pens and paper. There's going to be a lot of notes, a lot of good tips and tricks to take, and without further ado, welcome and thank you so much for coming, Patty.
Thank you. Thank you for the lovely introduction. But I'm sure that's not true, what he said about me. I'm sure there are many people doing as much. But I'm really excited to talk to you about this. And I would love, there's probably not the time and the space right now for us to do this interactively, but I will be here for a lot of the rest of the afternoon. So if you have ideas that you want to share with me, or thoughts or questions, please come up to me at that point. That's my picture, and this is me. Okay. I used to have really long brown hair, so this kind of freaks people out because it's really short. So the whole concept behind what we're going to talk about today is that there's this framework I want to talk to you about, where if you ask questions that are patient-centered, it facilitates listening. And so that's what we're trying to get at, is to facilitate listening. So the questions is sort of a first goal. There are a lot of skills that you can take some time to develop, and I think they're wonderful. Just starting with the efficient questions is actually going to get you a lot of the way there in terms of facilitating listening. But skills are also critically important, and I'm going to touch on a few of them. Certainly not a lot of them. One of them I'm going to touch on is paraphrasing, which is kind of the heart and soul of active listening. Anybody ever heard of the term active listening? A few people. Yeah, a lot of us learned it in school, and that was the last time we ever really thought about active listening. What about shared decision making? Who's familiar with this term? Most people. Great. And I would love to find out your understanding of what that means. In general, if we're going to be very generalized about it, it's that clinicians provide patients with information about their options and help them identify their preferences in the context of their, meaning the patient's, values, not the clinician values. That was a little unclear. I wanted to really underline that. And this is kind of taking into consideration the idea that the patient's the one making the decision when it comes to contraception or anything to do with their reproduction. And our role really isn't what we used to consider directive counseling. I don't know if anybody has heard that term before, but our role is really, as you can see here in the blue, to help people express, clarify for themselves how their values and their preferences and their goals start to inform their own decisions. And note I'm saying their goals, their preferences, meaning the patient's. And so I would sort of go to an extreme statement, very black and white statement, and say, for the most part, our values don't really have much of a place in terms of this. We're really thinking that we'd like to focus on what's important to the patient. So the patient is going to be contributing their values, their preferences, their goals, and very importantly, when it comes to contraception and any other specialty, but specifically to talk about contraception, their past experiences. We know data. We sometimes are tempted to say, oh, well, but that's not supported in the literature, this thing that you're experiencing. But just to say, if somebody's experienced it firsthand, probably that's going to be the thing that's going to be most moving to them. And if we look over here on the clinician contribution portion of it, we are there to help them clarify their goals and preferences and values. We're not helping them clarify their values. We're helping them express their values so that we can understand how they impact their preferences. But equally important and often missed is that it's our role, we know it's our role to provide information, but do we always bear in mind that it's our role to help the person integrate that information? So if there's one message about patient education I'd like to really start with right now and weave through all of this is that it's our responsibility not to just sort of vomit information on the patient. That was not my term. Jennifer Russo, who's one of my dear friends in the family planning community, said, vomiting information on your patient is great. It feels like you've just gotten everything out you felt like was important to get out, but did they actually take in, for one thing, what they needed to know, and for another, in a way that they can actually use that information? So that's kind of the standard I'd like to have us think about is, did we help that person integrate the information in a way that they can use it when they need it? So the questions that the way I'm going to put this out today is that it's a framework. And when I say a framework, there is a bit of a timeline involved with it. So that initially, in many cases, it's a great idea to start with talking to somebody rather than jumping to contraception. Start with talking to them about their reproductive goals. And these are the path questions you've heard so much about. And they start with, do you think you might like to have children at some point? Or if the person has already had children, you put in a more. If they say yes, then you go to the next question, which is a timing-based question. When do you think that might be? Very open-ended. When do you think that might be? And I want to clarify right out of the gate, surprisingly, that timing-based question doesn't have very much to do at all with choice of contraception. It does have to do with, might they be interested in a conversation about contraception because they don't want to be pregnant anytime soon or cause pregnancy anytime soon. But it's not about which method. It's about whether they need a conversation about pre-pregnancy care, whether they should be offered a conversation about contraception, but it's not about which one. Interestingly, the first and the last questions are about which contraceptive method, which is very counterintuitive, and that's probably the main clarification you need about this. Because the second question, when do you think that might be, is really, it's designed to help the person think about their life going forward, rather than the person they had sex with last night or the person they broke up with last week. It's to think about their life and where having babies or not having babies might fit into that. And then the last question, if the person has not said they would like to have a child anytime soon, and this person could be of any gender, then you go to how important is it to you to prevent pregnancy. Until then I'm going to talk about in a minute, but you can leave it off or not depending on what they've said. The only difference with these questions is if the person has responded when you say, do you think you might like to have more children at some point, and they say no, it wouldn't be very patient-centered to say, when do you think that might be? So you leave off the timing-based question, and hopefully that's intuitive for everybody. So we're going to drill down a little bit with these. To clarify for you about what we're seeking here is we're not actually looking to find out about pregnancy planning or pregnancy intention, and a whole other conversation could really revolve around why we're not fond of using the word plan with our patients, particularly our lower SES patients. I could talk to you about the literature about that. It's pretty moving and wonderful and very, very informative. But suffice it to say, plan's not a really resonant word for a lot of people. So we think about preparation for pregnancy, not planning. So what are we asking about then? What are we asking? If we're not asking about pregnancy planning or pregnancy intention, we're kind of asking about acceptability of a pregnancy. And I know that sounds different than the paradigm we've been talking about, but I think it's an important thing to think about shifting our paradigm a little bit, just to consider that for many people, it's about whether or not a pregnancy is acceptable. So at that point, once we've sort of clarified some of that, helped the patient clarify, that's the point at which we're going to be offering interventions that are consistent with what it is that they've set are their goals. And that may include pre-pregnancy care, it may include contraception, it may include both, and it may include helping them with fertility or potentially adoption. This can be used with teens. It's not an uncomfortable conversation with teens. You're not asking them, would you like to become pregnant? You're asking them about their future goals about having kids. Older clients, it's not off-putting Because if an older client is struggling with figuring out about their own fertility, these questions can certainly be utilized. And as well as any gender, any sexual orientation. And the hope is that if you are asking these questions to somebody who's been struggling with fertility, that they won't feel it as a stigmatism. They might feel it as maybe your support. That's the goal, is that they're gonna feel that as you're supporting them in their desire for pregnancy that might have been a little thwarted. So I talked about active listening, and I said that this whole Megillah is about trying to help facilitate listening. So the idea being that if you have a question that's been formulated that's non-judgmental, patient-centered, efficient, hopefully, open-ended, that your job then becomes, you learn the question, you ask the question, and your job then becomes the listening part, which really is the important part. It sort of doesn't even matter how you get to the listening part, but I'm hoping, really hoping very much, that the questions help facilitate that. It just makes it easier because it becomes a conversation. That's the thing I hear first from any group that I do a training with. This just creates a conversation. So that's the goal. So when we have this young woman, she says, you ask her, do you think you might like to have children at some point? And she says, yes, I definitely want to be a parent. Someday I'm pretty traditional, and family is one of the most important things to me, so I definitely want to be married first, which I don't see happening anytime soon. This is sort of an instance where it's an example of what you might get from that first question. This is a lot of information in a short period of time. That's where the word efficiency comes from. That's why they're efficient. You get a lot of information that's relevant information in a short period of time. So am I going to ask her, when do you think that might be? It's not very relevant to the conversation today. She's just told me it's not going to be until she gets married, right? And that's no time soon. So I'm going to take away that. But I am still going to ask the third question. So she definitely wants to be a parent someday, but what about until then? Is it important to her to prevent pregnancy? And shockingly, it's not always. So don't expect, the reason we're asking the question is, we don't know the answer. It's not necessarily true that everybody wants to prevent pregnancy until they're ready. Some people kind of want to be surprised. Some people just don't believe it's their place to have it's God's will. Some people just have ambivalence or perhaps just indifference. And that's all okay. None of that is a problem. We don't have to create a problem out of any of those things. So that's why that last question becomes very important in this mix, is that you start to find out a lot about the attitude, about acceptability, about pregnancy. So any answers to the PA being the PA of PATH, so it's parenting or pregnancy attitudes. So that's what the PA is. So anything that is in the realm of yes, like even, yeah, or absolutely, or anything in between, you go to the second question. And so I like to think of it very simply as, is it right about now, or sometime pretty soon, or is it no time soon? Because really, we're trying to help the person today. It's kind of like a slice in time today. So we're trying to find out the information about what what services we might want to offer for that person today in the office. So it doesn't really matter what's going to happen in 10 months, it matters what's going to happen today. So I did just use an example of somebody who was giving you information in response to the first question of, yeah, kinda, yeah, I'd love to have kids someday. Pay attention to people's body language and facial expression and tone of voice. That's just as important as the words that are coming out of their mouth. And of course, everybody knows the patient's also listening to your tone of voice, your body language, and your facial expression. So all of those things become important communication topics. So be aware of your face scrunching up when somebody's saying something to you that you might otherwise think you have a judgment about. And try to give yourself that information. Oh, look, my face is scrunching up. I kind of want to open my face up, and I'd like to not be feeling or acting judgmental in this case. So what is the until then about? It's how important is it to you to prevent pregnancy until then? So you are using that until then, you're taking actually those words away, until then, and instead you're putting in what the person told you. Okay, so the person told you, I'd like to be married, this woman the person that we just heard from, that she would like to be married before she's pregnant. So then you ask, instead of saying until then, you say, how important is it to prevent pregnancy until you're married? Or if they've said, my partner's in jail, and as soon as my partner gets out, we plan to have a child, and so you might ask, how important is it to you to prevent pregnancy until your partner's out of jail? I know it sounds like people might say, well, but the partner's in jail. I'm going to let you do the math on that one. So, or maybe they give a time frame. Sometimes people will give a time frame. It doesn't matter that somebody gives a time frame. Very frequently people answer with life events, but they may answer with a time frame. So then you say, how important is it to you to prevent pregnancy for the next 5 years? If they've said, I'd like to have a child in 5 years. And then if you don't have any other information until then, you could also skip the second question, as I'll talk about in a minute with adolescents, and just say to an adolescent, after they say yes or no, you could just ask the third question. And I'll show you what that might look like. It's a choice. It's up to you to do whichever you like. So at least 2 of those pictures are my daughter-in-law, and she lives here. And she has 2 children, which means I'm a grandmother, which means I'm extremely pronatal now. Anybody heard that term, pronatal? So if you think about an x-axis and a y-axis of people that are, so this is how much you want to be pregnant, and this is how much you don't want to be pregnant. Okay, so think about that axis. So if you're really high up here on this axis of wanting to be pregnant, you're very pronatal. And if you're kind of high on both, I really, really want to be pregnant, I really, really don't want to be pregnant, that's where ambivalence comes in. So I'm firmly, as a grandmother, right over here. Keep them coming. That's mine. So you guys can guess which one she is. Not Patty Duke. So this question with teens could be simplified if you want to. You can certainly ask a timing-based question. Some people are uncomfortable asking a teen a timing-based question. Most of us rationally and reasonably understand the teen probably doesn't know the answer to a timing-based question. So if you think the teen will benefit from thinking about their life in that way, great question to ask. If you want to leave it off, great thing to leave off. It's really an option. But if you leave it off, and you say to the teen, do you think you might like to have children someday? And they say, yes, then you would say, how important is it to you to prevent pregnancy until then? If they say no, you say exactly the same thing, except instead you say, how important is it to you to prevent pregnancy? And in general, you leave off the until then if the answer to the first question was no. Do you think you might like to have children someday? So not only do I not ask a timing-based question, I don't say anything about until then, because that would be silly. So this is that guy, this is that person who's saying, no, I'm done, like done, totally done. So do you think you might like to have children at some point? No, I'm done. More children at some point? No, I'm done. So am I going to ask then, when do you think that might be? No, I'm not going to ask when do you think that might be. So I'm also going to take off the until then, so I'll just say, how important is it to you to prevent pregnancy? Now, I said earlier that the first question and the third question are the ones that can inform birth control selection, right? Which contraceptive method is consistent with somebody's goals. So you can see that in terms of the first one, you get there's a lot of reasons that you can figure that would be related to contraception. And the last one, you could also figure that there's a lot of reasons that would relate to contraception. And I said that the timing-based question really isn't, because any birth control method can be used for any length of time, right? The only one that even impacts return to fertility is the injection. All the rest, if you've said to your patient, if you want this out at any point, come in, we'll take it out, and your ability to get pregnant will go back to whatever's normal for you immediately. So that's already been clarified. You've clarified if it's a method that you've put in the person's body that they then can't control, only you can take it out, then you've reassured, if you want it out, it's out. And I would really urge everybody to think about that kind of a sentence if you're going to be putting something in somebody's body that makes it so that they can't get pregnant. It has to be sort of by the exact same token, like Dr. Rodriguez said, of if you want it out, it's out. So that should be just sort of part of the texture of the conversation. So the how important is it to prevent pregnancy? Let's think about this person here. And I would think of it in the context of one of the most neglected conversations that happens is about vasectomy. I don't know if that's been your experience, but how many of us have had a patient who's come in who has the ability to get somebody pregnant, yet doesn't feel much reproductive autonomy? They may not actually experience a lot of control over whether and when they become a parent or become a parent again. So asking this person, about vasectomy, their interest in vasectomy, is very appropriate, and that's where the timing, that's where that how important question starts to really inform contraception in a way you might not have thought about. We think about it in terms of effectiveness, but do we think about it about permanent contraception as well? Again, that's also with the first question. I say no, right? No, I don't want to be pregnant anytime, I never want to be pregnant, I never want to cause pregnancy, and I never want another child. That would be an immediate thought. You want to think immediately about permanent contraception at that point. So what about the person who answers yes to the first question? Yes, we've been trying for a while, actually. Or yes, we're thinking about getting started any minute now. Let's break that down, because again, you're going to be listening. And then depending on what they say, you're going to offer the services that you think might be helpful. So in this case, if the person says that they've been trying for a while, depending on the sense you're getting, maybe you're getting the sense that they've been trying for a while, meaning like a couple of weeks, and maybe you get the sense they've been trying for a couple of years, and that's quite different. So if they've been trying for a while and that a while looks like it has perhaps a little bit of negative emotion attached to it, or indicating to some degree that this is a problem for them, then you can offer help in that regard in terms of fertility support. So would you like to talk about any concerns you have about trying to get pregnant? You can just go ahead and offer it. I'm interested in answering any questions that you have about your ability to get pregnant. Otherwise, you might just go straight to a question about pre-pregnancy care. I've always said preconception, so now we're changing the language to be pre-pregnancy, so my mouth doesn't really work very well sometimes. So I'm going to posit this as another great, efficient, patient-centered question that doesn't use the word plan, as you can see here. It's kind of the idea of you are the fertile soil that's prepared if like in the United Kingdom, they say you fall pregnant. So if you were to fall pregnant, you'd be prepared for that. So it's a bit passive, but it's also a different kind of an idea. Planning is a specific thing. Preparation is much more generalized and much less, you don't have to be planning it to be prepared. So this is another, as I said, this is a question I would also think about using just sort of verbatim. Would you like to discuss ways to be prepared for a healthy pregnancy? And you just fill in the blank with what they've said. Again, it's a lot of fill in the blank because this is supposed to be facilitating listening, and listening a lot of times involves reflecting back to the person about what they've said. So in this case, you're just going to fill in the blank with, since you've said if it happens, it happens. Since you've said you've been trying for a while. Since you've said you're open to it. You can take that to whatever their answer is. You can put it in here. And then following that, let's say the person has said they don't want to be pregnant anytime soon, which, by the way, is really the only thing that you need to know in order to get to this question. So if they've said no, they don't want to be pregnant anytime soon, you would think about offering a conversation about contraception. So would you like to is talking about contraception something that you would like to do, or is it appropriate for you? Just so you're not assuming. But then once you're going to talk about contraception, this is sort of like a key in a lock. It just opens up a lot of information. And I'm going to suggest that the information you want is what preferences does that person in front of you have about their contraception. You want to understand which characteristics of methods they're looking for. Or they may not know they're looking for it. They may just know they don't want this, or they liked that once upon a time. So really you're trying to help them expose what their preferences are about characteristics. And I want to say something that seems a little strange, which is in these conversations, it's very difficult for healthcare providers to hold back conversations about methods. That's not about a method. You're not saying to the person, what method are you interested in? This is quite the reverse. And you're not immediately offering a method when they give you one answer to this. Because you need to know more. You need to flesh out more about what what characteristics they're seeking, or that they're interested in, or they don't want. So, for example, you might have had the person answer, how important is it to you to prevent pregnancy until you're married? And you might, the person may have answered, extremely important, nothing could be more important. Or they may have said, yeah, no, it's pretty important. So you can say, so since you've said that, you can segue to one of the things that's important to you about your birth control is that it's really good at preventing pregnancy. since you've said that it's really important to you to prevent pregnancy. Now, obviously, you've already established before you ask these questions about contraception that the person wants a conversation about contraception. I think that goes without saying. So then you would say, for example, so I'm assuming that one of the things that you're looking for is that your birth control be really good at preventing pregnancy until you're ready. And here's the thing that you're going to be saying repeatedly, probably. Do you have a sense of what else is important to you? And what else? So until you have a pretty rounded picture of how the person feels about the things particularly the things on your left, the things over there. Those are the ones I think it's really important to go ahead and query proactively about. The ones on the right, so effectiveness, hopefully you've already found out about because you've said how important is it to you to prevent pregnancy. Hormones, somebody will probably volunteer if they have an opinion one way or the other. Length of use. Length of use is one where we get stuck a lot. We like to peg somebody's use of contraception to whatever the specific number of years are until they think they want to have a baby. If somebody says, I'd like to have a baby in 3 years, does that mean they're going to have a baby in 3 years? Does it mean maybe they might have a baby in 6 months or in 5 years? It's really not relevant, I would say. So length of use, since you are hopefully going to say to your patient, if you want this out for any reason, come in, we'll take it out for you, and your ability to get pregnant goes back to whatever's normal for you immediately. Hopefully they understand you don't have to use a 3-year method for 3 years or a 10-year method for 10 years. You don't have to, it's fine to keep using your daily method for the entire time you need it. It's fine to use your monthly method for as long as you need it. So any of them can be used for any length of time. So I'm going to take that off the list. Control over removal, I would hope that we've already established early on in this conversation that and throughout the conversation, that they're the one in control over removal. So yes, I would like to understand if they have fear about that and concern, which if they did, it would be reasonable given some of our attitudes in the way we've treated people about contraception and about their fertility. So I want to find this out, but I do think that if you're having a non-judgmental conversation and you've made it very clear that you're completely open to hearing what it is that they're saying about their own reproduction, then this gets handled. They will express this. So I wouldn't say, do you have concerns about control over removal or not control over removal? I would allow that to happen in the conversation naturally. Same thing with an object in the body. I think if you just sort of point out to somebody and say, some methods are an object you put in your body and some methods are not, I'm not sure that that's really the way to talk about it or think about it. Anybody ever found a patient have a difficulty expressing their concern about an object in their body? If somebody has a concern, they're gonna tell you that. Return to fertility, there's one method that you need to be proactively telling somebody is going to impact their return to fertility potentially. All the rest, when you stop using it, your ability to get pregnant goes back to whatever's normal for you immediately. But on this other side, if you haven't found out that the person has a need to conceal their contraception, early in the conversation, you can go right down a rabbit hole with a potential birth control method that's perfect for all the other things that they're looking for. But you know what? A lot of people get amenorrhea, and that person's parent is watching to see whether they're getting a period once a month. Or they love this whole idea of using oral contraception because it's going to clear up their acne, and they have these menstrual cramps, and they want to be able to, but they can't have supplies in their house because every time they have supplies, pills, patches, rings, their partner throws them out. So in what way do they need to conceal is another important thing to figure out. I would say lead proactively with non-contraceptive benefits. Do our patients know that these methods can protect against endometrial cancer, or ovarian cancer, depending on what the methods are, colon cancer? There's a lot of really great, they can treat acne sometimes, great benefits, dysmenorrhea, menstrual control. So I think that's a good one to lead with as a proactive. Some methods have benefits above and beyond their ability to keep you from getting pregnant. You could list one that you think was appropriate to that person, and then see how they feel about it. And then definitely, very important, all methods of birth control that are in the first and second tier of effectiveness have some impact on the way the menstrual cycle happens. They're not bad. That doesn't mean that this is a bunch of side effects, but it is something that is going to be impacted. And when you survey patients pretty much across the board, side effects is one of the things that's really important to all of them. So we need to not poo-poo that, and that is something that we would want to query about proactively. So paraphrasing, it's not easy, and it's a bit complicated for this kind of a conversation that we're having today because it's really best if you practice it. But what paraphrasing isn't is repeating back what somebody just said to you. In fact, if you repeat back exactly what your patient just said to you, that's not a way to really build credibility with your patient. They're going to sort of look at you like, yeah, pretty sure I just said that just a couple minutes ago. I just said that. So it's not repeating. It's really trying to get clear about the gist of what they're saying. And very importantly, not just the gist of everything they're saying. What's the important kernel of what they're saying? Important meaning to bring our conversation from you walked in the door, I asked you these efficient questions, and you're going to walk out the door having made choices about contraception, because this is a topic of conversation today is contraception. You're going to walk out with a contraceptive method that is really well aligned with your goals and your preferences, and we're going to do that in an efficient way. And so there really is a goal to the conversation. We are not just sitting there wanting to hear somebody talk about whatever. That's what paraphrasing does. You get to listen for the parts that are really important and then pull them together into a paraphrase or rephrasing to the patient in other language. The paraphrase has three clauses in the sentence. The first one prepares the person that you're going to be paraphrasing, and the last one checks that you've gotten it right. I'm hearing you say, bloody, 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 do I have that right? Or, it sounds like, is that correct? So any words that you like, but it's nice to, when you're practicing, start with, so I'm hearing you say, or something like it, and end with something confirmatory like, do I have that right? Once you're confident that you're doing this in a way that's really working for you, sometimes you leave off one or the other or both. But in the beginning when you're practicing, and I would strongly advise practicing with your friends and family, so that if you do end up kind of stumped and sitting there repeating exactly what the person just said, you're just repeating what your child said, and it's probably not going to have much impact professionally. But it's good to practice. So the other thing that it can do for you, so as I said, it can help you to make the conversation go from here to there, which is always really helpful to be efficient. If you're being patient-centered and also efficient, that's wonderful. But it also lets the person know you're listening. And lets the person know that you are accurately perceiving who they are. Or at the very least, and this is equally valuable, are interested in knowing who they are and understanding who they are individually as a person. When I say, is that correct, or do I have that right? What if I get it wrong? What if I just said something and the person's like, no, 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 that's not correct at all. No, no, that's not at all what I mean. We might have a tendency to think, oh, I just got it really wrong. I messed up in some way. And I would say it's probably quite the reverse. Number one, the patient knows you're trying, that you're interested enough to ask. Number two, the patient gets an opportunity to speak their own preferences, values, goals, thoughts again. Which means that their process of clarification, remember, one of our jobs is to help people clarify. So their process of clarification is becoming refined. So it's a good thing if you get corrected. Sorry, I know it might not feel good, but it's a good thing. Another thing you can say instead of a paraphrase, if the person has not really told you what it is they mean, but you have a pretty good idea that you can guess based on some of the clues they've given you, you can fill in the blank. And in this way, you're not actually putting words in their mouth, but you are actually offering up a paraphrase, essentially. Many of my patients say that, and then filling in the blank is a very useful tip and tool. Other alternatives, you really like I hear you saying you really like the idea of continuing to use a method without hormones. You might even go further and say, but that you don't have to worry about, or add another thing that they said that has hormones, but that isn't going to cause this, whatever the side effect was that you had. So putting 2 or 3 ideas together is a really good thing to do with a paraphrase. Oh, I just want to say here, I'm going to talk about this with empathy as well, but that word, wow, a really helpful word. There's sort of 3 words that are really helpful. Wow, concerning to you, hard to deal with. Very appropriate a lot of times. It allows you to listen in a more open-ended way a lot of times. This one you're all doing all the time anyway. You are pointing out positives to your patient all the time, and I would suggest you might consider consciously trying to do that very frequently, listening for the positives all the time, and the minute you hear them, pointing them out. It's not going to waste a lot of time. It's seconds that it'll take to do that. And the shift in terms of rapport building is pretty magnificent. I've been in the room doing direct observations very frequently with clinicians and patients, and you can see their body go from like this to open. They start leaning forward. They become much more open to the interchange with the clinician, which saves time. So anything you can think of. Condom use. They would like to lose weight and they've been doing a really good job with their diet. Whatever it is that they're doing, which is demonstrating that what they're doing for their life is a health-supporting behavior that they themselves are proud of, that they themselves are trying to do. It's not that we're patting them on the head for doing a good job with something that we think they should be doing. And it's a little tight line to walk. It's really reflecting that you are seeing that they're doing things consistent with their own goals for their health. So things like, it's great that you were so strong in standing up for yourself and using condoms. I use this a lot. I wish all my patients knew that. When a patient has something that they have said, a piece of information that's accurate, I would remark upon that, because not everybody does know that. And it's great that the person does know that. It's great you know that. I wish all my patients knew that. And I love to always point out for adolescents that they're very mature. It's just sort of the world we live in that I think most adolescents are probably going to appreciate that, and it will help to build rapport. And I said we were going to talk about empathy. I'm not going to go deep with this. I would like to point out, though, that it's not really demonstrating empathy to label the emotion that you think somebody's having. Because probably everyone in this room has a slightly different definition for the word anger or frustration. We probably all have our own take on that. So if you say to somebody, you seem angry, probably just as much going to reflect that you understand that they are having a difficulty here by saying it was hard to deal with. And it's very helpful to validate it and say, anyone would find that really hard to deal with. So empathy doesn't have to be that you're labeling somebody's particular experience, but that they see that you get the experience that they're having. You appreciate what it is that they're going through, and that they are going through something, or that they're expressing concern about something, and that you see that and you understand it. Obviously, you don't ever want to say, I know how you feel, except if you're in a support group and you both are cancer survivors and you really do know how they feel. That's a different context. But if you're trying to empathize with somebody, what are they going to say? I know how you feel. What are they going to say? No, you don't. Because really, you probably don't, actually, because you really actually don't live inside that other person's body. Another thing with empathy is that you want to match the level. The person says, I go to bed every night hoping that I do not wake up in the morning, and I wake up every morning devastated that I'm still alive. And you say, well, that must be hard to deal with. Or the person says, I find it really hard to remember my pills all the time. And you say, oh my goodness, I can't imagine how concerning that must be for you. That's not getting it. So it's really some of the nonverbal stuff that's important as well. There's a lot of misconceptions our patients have. We know this. There's a lot of things that we would love to correct. I'm just sort of outlining 4 of them, or sort of bringing out 4 of them here. I'm not going to go through any of these, but I just want to say you can assume many of your patients don't really know there's a difference in effectiveness. So having a tiered effectiveness chart or something in your room that's a visual aid, perhaps from bedsider.org if you don't know about that already, having something that's a visual aid that shows pictorially that there's a difference in effectiveness between different methods is something that's really valuable, because there is this misconception. Very frequently people underestimate their own or their partner's fertility. Part of that's because of the way we talk to people. It only takes once. Oh, I did have sex once. I didn't get pregnant. I must not actually be all that fertile. A lot of people believe that contraception harms their ability to get pregnant in the future. So that's, again, that really important proactive piece of information. Your ability to get pregnant goes back to whatever's normal for you immediately. And Very common. I'm sure you've all seen this a lot. People believe pregnancy is safer than contraception. So that's another thing that's quite important to clarify for people. But you don't clarify it by saying, you're wrong. Let me correct you. You're gonna really want to think about starting with a positive. And you want to be respectful in the way that you're dealing with that. So the person says something completely bizarre, off the wall, and what you're in your mind, you're thinking, what on earth? What? But instead, it would be great to be able to turn that around and use, again, that concerning to you little tip, which is what's concerning to you about fill in the blank. Or tell me more about that. Okay, so very open-ended, letting the person explore what it is that they're talking about. And then when you're not really getting much of anywhere and you're getting yourself a little bit frustrated and you know that the time is ticking, you can throw out something like, different things are concerning to different people, and I'd like to understand your particular concerns. The person doesn't want a foreign object in their body. The person doesn't want hormones. Those are things that people might object to. And instead of saying, why on earth would you be concerned about hormones? They're great, they do all these wonderful things. Instead, many people have different concerns. Can you tell me more about what's going on for you with this? So I said to start with a yes rather than, or to start with a positive rather than going directly to disagreeing or correcting somebody. So the idea is that you start with something positive and you build on it from there. You build on the positive that you've just established with a piece of information that is essentially correcting a misinformation or the same thing as telling them the true thing about science that they had kind of backward. But instead, you're first going to start by acknowledging something. And what you want to acknowledge is either agreement, empathy, or validation. Agreement. Yeah, that's absolutely true in this context, but in that context, maybe not. Demonstration of empathy. Yeah, I can see that that was really concerning to you, and interestingly, and then fill in your information. Or, yeah, validation. Many of my patients think that. I can totally see why you would think that. I hear that all the time. And then give your information. So some examples, the person who says something very bizarre that they heard on the internet. Has anybody ever had that happen? No, never, right? And you want to say, I'm a healthcare provider. I can actually give you the information right here. And it can really trigger people, especially, we go to school for a long time and we really do a great job of learning throughout the whole course of our professional lives, and it can be really triggering for us, for somebody to come in and tell us a piece of information about science that is actually not right. And so we're sitting there going, what? That's just another example of Dr. Google. Just ignore that. So instead, you might want to think about, it's great you took the initiative to look that up on your own. I can see you're really interested in taking care of yourself. I have a great resource for you that I think you're going to love. And I personally write bedsider.org on a sticky note and hand it to my patient as an individualized recommendation with everybody. But it's individualized. Anybody ever heard of an information sandwich? Yeah? You're sandwiching information between questions? So you're asking the efficient questions, like we've just talked about. They give you a response. You now know, because of their answer to the questions you've asked, a piece of information that you think they might need or they might benefit from, or a clarification they'd benefit from. So our temptation, and if I were to tell you what I see all the time when I see observations, it's that we are really into pathophysiology and physiology, and we want to let the patient know all about all the things that we want them to know about. A lot of stuff, a lot of pieces of information. How many pieces of information do you think people can take in at one sitting, or at one go? 10, 3, 7, 1. If you can limit it to 1 or 2, you can be much more likely to think that they might actually integrate it. Because to integrate information, I have to have heard it, paid attention to it, understood it, remembered it, and then integrated it enough so that when I need the information, oh, I'm having that exact thing that they told me I might have. They said I could do this about it. So now that's the person using that information, and that's what I want. Has anybody ever had a patient come in after you've started them on Depo and they tell you that nobody ever told them they weren't going to get their period? Did nobody ever tell them that they weren't going to get their period? You think that actually happened? What happened? They either didn't hear it or they didn't remember it, but they certainly didn't integrate it. So the idea behind asking a follow-up question is, asking a follow-up question gives the person the opportunity to interact with the information, and when they interact with the information, they then have integrated it naturally. It's kind of like why when you teach something, you know it better than when you just read about it. It's because you've interacted with it in a way that's really meaningful so that you actually have it now. You have that information inside of you. Great questions would be things like, how would that be for you? When it's an appropriate question. Or, has it ever happened to you before? When it's an appropriate question. And then, how did you manage it if it had happened before? Or if it hasn't ever happened before, well, how do you see yourself managing that? How about for somebody who's going to use an implant? How would it be for you if you didn't get your period while you're using the implant? Because you've already given the person the one piece of information that many people who use this don't have their period while they're using it, or they have little or no bleeding. That would not be good. Okay, I could say, okay, let's move on and let's talk about something that won't cause amenorrhea. I wouldn't use the word amenorrhea with most patients, right? You're getting your period. So I could either just say, okay, well, you're not a candidate for any of these because you don't want amenorrhea, so let's move on. Or I could query a little bit further and find out what's going on, why, what's the reason. But what I want to say to the person, why on earth would you not want amenorrhea? Many of us in this room might actually feel that way ourselves, like, why on earth would somebody want a period when they don't have to have one? So instead, might be good, rather than saying why, which is generally a bit of a challenge, what's concerning to you about that? What's concerning to you about not getting your period? So what about when the person says, it's not healthy not to get my period? They just tell you. They tell you the medical facts. That's the same idea of, like, they read something that's incorrect on Google and then they go and tell you about it, as if it was a fact. So we get triggered. If you find yourself starting to get triggered by, like, I think, hello, I'm the healthcare provider in this conversation, not you. So if the person says, my mom always told me or my grandma always told me it's not healthy not to get my period. If I'm going to find the yes, before I explain that it actually in this context is healthy, if I'm going to find the yes, I will posit that it might be best to actually, my first choice between agreement, empathy, or validation would probably be agreement, because I'm actually finding something concrete to agree with. It's actually factual. So in this case, I'm going to err towards agreeing with the fact rather than empathizing or validating, and I'm going to tell this person that her mother is completely right. And whenever you can tell somebody their mother is completely right, or their grandmother is do that. Their grandmother is completely right. If you're not using hormones, contraception that has hormones in it, then it is important that you get your period regularly. You could say, I'm really glad you know that. I wish all my patients knew that. I wish everybody knew that if they didn't get their period, they need to come in and see me to find out what's going on, unless they're on contraception that has hormones in it. So that you could follow that by saying, interestingly, when you are using hormones in your contraception, it protects the lining of the uterus, and you can pick up another visual aid. The only really important visual aids I think everybody really probably, it'd be helpful to have if you're having these conversations, would be one about anatomy, of both kinds of anatomy that we see, and also this tiered effectiveness chart that I talked about. Because you can just lift up the little picture of a uterus. This is the place where, if you ever had a baby, or when you had a baby, if the person has, that's where the baby grows. This is the lining of that. And actually, when you use hormones, it gets super thin. And if you're a lining of a uterus, it's very healthy to have a thin lining. People also like the word thin. It's a good word. Thin's good. And I actually go further and say, in fact, it actually, because it's doing this, it actually prevents cancer of the uterus. So if I right now were to say to you guys, do you have any questions? Because we're done. I'm done. And I want to get out of here. Or how does it feel when I say to you, what questions do you have? Or specifically, like if you're talking about contraception, you might say, what questions do you have about X, and fill in the blank. So that's a really good kind of way to make it not be all day when you say, what other questions do you have? And they start to do whatever question they had. You might say, what questions do you have for me about such and such? But much better than, do you have any questions? Did anybody, when I said, do you have any questions, did it feel different than when I said, what questions do you have? It's inviting a question. So what questions do you have? I'm done. Seriously, you could ask questions now. Yeah.
I have several questions, but I'll see if others have questions. So,
She said she has several questions. She'll see if others do. She's going to give a little time for others to ask questions.
so one of the questions I have, I love that this works for males and females. I'm wondering what your counseling looks like if they would like to have a child soon. It's a male, and he would like to discuss ways to be healthy, to have a healthy pregnancy. Like, what does that preconception piece look like
For a male, yeah. Well, that's the science of it. So if you're asking a counseling question, it's different than if you're asking a science question. So it's like, yeah, are you asking from a counseling perspective, or are you asking from a science perspective?
Well, I guess I'm
Because I think you'd want to, if from a science perspective, you'd want to check anything that they would be doing that might be negatively impacting their ability to create sperm, or to be in a healthy position to be parenting, those sorts of things.
So I guess my question is more about the methods you use. So do you go through a list of like, this affects sperm quality, you know, like do you run through it, or do you sort of ask about their, and I guess
That's a great question. She's saying, how would you go through this? Do you do it as just running through the whole list, or do you ask a question? I'm so glad you asked that, because I would say precisely the same information sandwich would apply. Whether somebody is seeking the information or being offered the information, they still can't take in that much. So giving information and then asking questions about how would that be for you, or is that something that you do, or have you had this issue? Those are ways to help them, even if it's a person with sperm talking about pre-pregnancy.
If they say, yes, I would like to know how to have a healthy pregnancy, what would be your the very next thing you would do?
With that person? Well, it would depend on what their situation is. If you're saying that they're a person with sperm, I would also want to find out about how that's going to happen for them. I'm not going to. Right, because what if they're not in a heterosexual union, or what if they are single? Or, I don't know I need the background for that person.
Okay.
Yeah. Maybe it's a trans man. They have a uterus, perhaps. Maybe they don't anymore, but I want to find out who that person is. And that's kind of the more generalized principle, is that I want to ask enough questions so that I've clarified who that person is and what's going on for them today. And then, once I have a sense of what that is and what they need to know, follow that piece of information about that I figured they needed to know with another follow-up question. That's why it's a sandwich.
Okay.
Kind of like,
I guess what I'm struggling with is, how do you get into the preconception guidance?
yeah, just like that. I mean, you've asked the question and they say yes. You start asking the questions about it.
So you would say, do you feel like there's things you're exposed to that put you at risk for an unhealthy?
You could say that. Matter of fact, ACOG just came out with a new guideline for pre-pregnancy care, so you can just take it right out of there and ask questions about each of those things. Give information and ask questions. Yeah. Another thing I wanted to point out about that best contraception question, do you have a sense of what's important to you about your birth control? One of the things I get from clinicians frequently is the feedback that that's too abstract of a question. So I think part of what they're responding to is that sometimes the patient hasn't ever considered that question before, and they need a beat, they need a moment to think about the question. So if the patient gives you a very blank look, pause, just wait. 5 seconds can be an exceedingly long time. Just give them 5 seconds, 7 seconds to come up with an answer. The other thing you could do is you could clarify at that point. If they say, I don't know what you mean, and I would let them say, I don't know what you mean. Give them a minute to say that, not just a confused face. You can say, well, some methods have such, and some methods are just the things we described as characteristics. Some methods have this, and some methods have that. Is that something that's important to you, for example? It's very, sometimes a pause is the best possible trick. And just count to yourself. I mean, if I were going to be super dramatic, I would just sit here and not say anything for 5 seconds. But I'm not going to, because we're running out of time. Any other, what other questions do you have for us? Okay, yes?
In your conversation, it seemed very set on pregnancy versus not pregnancy. Is there ever a discussion about sexual enjoyment or arousal?
Oh, that's my favorite topic, other than PAV. I talk about that constantly. It's not easy. It's not an easy sell in this culture right now. I mean, I don't know why people think we're having sex and needing contraception if it's not for pleasure and arousal. I mean, okay, that's wrong. People have sex for lots of reasons. So I don't mean, I'm being glib. I understand that people have sex for many, many, many reasons, but certainly pleasure is part of it. And yes, I bring that up all the time. It's not part of a contraception framework per se, but your point is extremely well taken, is that we use contraception to have sex, not the reverse. And a contraceptive methods impact on our sexual arousal, sexual desire, our bleeding, and whether or not we want to have sex when we're bleeding. All kinds of things, ways, condoms, lots and lots of ways in which contraceptive methods impact sexuality and our sexual experience. And if we completely neglect and ignore those, we're missing the boat. So I'm gonna now add a question. I'm gonna ask people to help me figure out best questions about that, and I'm going to add them into that. I do it myself, but I want to add them into this, so thank you. That's what we're going to do. So if any of you have really good sexual history questions, I'm really interested in expanding into actual kind of the full tilt boogie about sexual history questions. So if anybody has ones that work particularly well for you, one researcher that I am friends with, Dennis Fortenberry, works a lot with adolescent sexuality, and his best question is there anybody in particular you're talking to right now? I would never have thought to ask that question. Has anybody ever asked a question like that? Of a teenager, an adolescent? Because talking to is like hooking up. It has all these different meanings, but it has to do with things that could get you pregnant or cause pregnancy. Sometimes. What other questions do you have for me about this? Or about anything? Yeah.
Can you talk about how the partner's wishes come up or fit into this? It seems like it's always done with individually, of course, but the partner's desires have impact on the couple.
The partner's desires do have a lot of impact, and we know that from data. You're absolutely right. And I think that's another thing you could add as a question. Does your partner have an opinion about this, or has your partner expressed any kind of interest about this? Or is there something in particular your partner's been saying to you about this? And reproductive coercion is, I just want to say we have a new study out of Pittsburgh that Sonia Barrero was a lead author on. And they looked at low-income men. It was really pretty balanced in terms of ethnic background, racial background, but all low SES. Pretty much across the board, these men expressed little or no reproductive autonomy. I don't have control over whether or when I have children. And they also expressed that pretty much across the board, reproductive coercion was a common thing both ways. Both ways. So I think we are just sort of scratching away at the tip of understanding these things, really. We've been really good about starting to bring the concept of reproductive coercion into our conversations, but now I think we need to look a little bit deeper. They had a lot of quotes of, she was doing these things so that I was going to pull out, and she was doing all these things to make sure I wasn't going to pull out. For example, there's a lot of really fun examples of that. Not fun. Sure. And there's not really a right and a wrong way to do contraception counseling. This is a framework I'm suggesting. I do think these are questions you can use verbatim and see how you like them, try them on. I do like the idea of starting with reproductive goals and then asking a very open-ended question about contraception. But What if your patient says to you, what do you think is best for me? Well, what do you think I should do? That person's asking for directive counseling, and I would say the most patient-centered thing to do would be to give it to them. Because they're telling you what they want. They want you to tell them what you think. You could ask more questions at that point if you wanted to try to get a better sense of what your recommendation will be. But I don't think you have to force shared decision-making on somebody when they're asking for something else. Okay, well, thank you.